Hello, I'm Sean Shea. I'm the actual designer of the interview that you're going to be utilizing here at Rogers Memorial Hospital as you do your intakes. I've been studying interviewing for almost 3 decades now, and I'd like to think that we've designed an interview that's going to be something very enjoyable for you, but even more important, obviously, something that can really help the patients that you're trying to help. What we're going to do is a series of little modules or mini courses that'll give you some ideas both about how to utilize the interview, but also what the pain is like that the patients are suffering from who are calling you. So it allows you to engage more freely and more deeply with these people. In fact, engagement is our number one thing. Let's just take a look at this on our slide. The number one goal in developing this particular interview at Rogers Memorial Hospital was the idea of to improve and help with engagement. One of the things that's exciting about what you're doing is that you are actually, if you think about it, you are a gateway encounter for anyone who is trying to enter any of the services here at Rogers Memorial Hospital. By a gateway, I mean you are the very first person that they have had contact with. This is so important to people because that first contact, it's just like meeting a stranger. Your first couple of minutes with somebody, you often make a read on who they are. This is their first contact on who we are here at Rogers Memorial Hospital. The bottom line is, if they feel that you are a kind person, a person who's engaged with them, who cares about them, it's going to have a tremendous impact. In fact, let me show you a little bit about what that impact is like. First of all, engagement enhances validity. Now, one of the things for you to remember as an intake specialist here is that we know that you're not a clinician and we're not asking you to do clinical work. You're not developing the diagnosis, etc. You're always talking with a psychiatrist. It's the psychiatrist who will make the ultimate clinical formulations about diagnosis, etc. But that psychiatrist, on the other hand, is relying 100% on you to provide the very best possible information for them about what this particular person is experiencing. So the validity of the information will determine just how good the fit will be and how much we can help this person. What helps with validity? There's no doubt about it. Engagement. People don't like to talk to people that they don't like, especially about difficult things like suicidal thoughts, or perhaps they've been victims of incest or something like that. They're only going to share that with somebody that they think is a genuinely caring, kind human being, which is what we're going to provide for these people when they first pick up that line. So actually, your ability to engage has a tremendous impact on the validity of the information the psychiatrist is going to need in order to make a good decision. But engagement does even more than that, as you can see. It impacts on the future healing that's going to occur on our inpatient units, our IOP, or partial hospitals, or residential settings. Because once again, as a gateway, when they are done with the interview with you, they have already decided, for the most part, whether they like this particular place. And so if they do like us, if they do feel comfortable with us on the phone, the first day that they come here to, say, go to an inpatient unit, maybe they've never been on one ever in their lives, you know what? It's a scary thing. And when you approach that door, it's frightening. But if they liked you, if they remember you as they're approaching that door, they will anticipate that on the other side of that door, there's going to be kind and caring people. It makes the entire process so much easier for these patients. But the other thing is, it helps trigger the entire process. If they're anticipating that they're not going to like the people on the other side of the door, they probably won't. Whereas if you've made a good engagement, you've kick-started the process, increasing the likelihood that all further treatment here is actually going to go better for this particular patient or client. Now, there's another thing that the engagement does, right on the spot, when you're talking to these people on the phone. Sometimes you're the first mental health professional of any sort that they've ever spoken with or had any type of contact with. Other times, they're just simply in such tremendous pain that one of the things that can happen is their pain will be decreased simply by the fact that they are being listened to by someone who genuinely seems to care about them. So it's sort of nice to wake up in the morning and tell yourself, you know what? I'm going to relieve some pain today in this world, and that's something that this job offers you a privilege and an opportunity to do. It all depends on the engagement. Which brings us to our fourth thing. You know what we do on that phone? For many of these people, we create or invite the first spark of hope. Now, some of us have had to deal with our own mental illnesses or disorders, or our siblings, or our parents, or family members, or friends. And the bottom line is, these are tremendously difficult things to deal with. And the bottom line is, these people are really in desperate need of some sense of hope That's what you're going to bring to them through this exchange on this particular phone contact, because we can do a lot of good things for people here at Rogers Memorial Hospital. Now, with that in mind, I'd like to take a little look at our next slide to actually address, well, what kind of interview is this? Well, it's a triage interview. You know, you watch on TV about triages in emergency rooms or on a military front or whatever. Well, what a triage agent or nurse is doing is, depending upon who's walking in the door, depending upon how severely they're injured or what their problems are, they make a triage decision. How fast does this person have to be seen? Do they need to be seen before this other person? Can they go after this other person? And then what specialty unit do they need to go to? That's what you're doing here at Rogers, is that what you're going to do is you're going to try to understand the patient's problems and their treatment preferences. And everybody is entitled to their own treatment preferences. You're going to try to uncover this information in this interview, and then you're going to couple it with something else, which is, as you can see, the objective database. What do their symptoms look like? What are the stresses that they're coping with? What is their life circumstances like? And what we do is we take those two sort of bags of puzzle pieces, their problems and their treatment preferences, and then their objective symptoms and the database and their stresses, and we put them together. We put the jigsaw puzzle together. And what we call that is making an appropriate fit of the program. In other words, we have triaged the person to the best possible fit. Now, once again, you're not doing the triage. That clinical decision is made by the psychiatrist. But what you are doing is you're providing the information for that psychiatrist to make the best possible triage decision for this particular human being. Now, how do we do it? And how are you going to do it? You know, one of the things that we want is that as you're doing this interview, we want you to know exactly why you're asking every question that you're asking. Almost every question that is ever asked in this interview, other than just simple background demographics, is actually being done with triage in mind. So how do we make the right fit for the person? Well, the first thing is, as you can see from our slide, you got to have the right diagnosis. One of the things that is pretty unusual about Rogers, and is special about it, is we have an incredible variety of different programs here at this particular center. Well, what that means is there's programs for people with eating disorders, there's programs for people with OCD, there's programs for people with PTSD, there's people or programs that help people who have substance abuse problems that are concurrent with their other mental illnesses. What that means, though, is you don't want to send a person with an eating disorders to the OCD unit. You don't want to send somebody with PTSD to just a general unit, because we have specialized units where the care can be even better for that. This is all done, as we can see by the slide, by a correct diagnosis. The psychiatrist is counting on you to provide the information that they can make that correct diagnosis. The second way we fit an individual who is always unique to a specific program here is the severity of the dysfunction. Now, people are going to vary. There's going to be people who, quite frankly, don't need our services here. They can be handled as outpatients or see an outpatient therapist. There are other people at the other end of this that are acutely suicidal or in such immense pain that they are decompensating, that actually need to come into an inpatient unit for safety purposes and to ability to get them the best possible care. So one of the things that we have to do is we have to find out just how severe is the dysfunction. Is this a person with obsessive compulsive disorder who maybe an hour a day has some rituals, very painful, but they have to deal with, but they're functioning okay at work or in their house? Or is this a person, like a patient I had who had rituals that continued for hours and hours on their hands, washing them over, that literally made them dysfunctional at work? Well, this is going to determine what we need to do to help this person. Obviously, the more dysfunctional the person is, the more we have to provide intensive care for them. You're going to uncover the information that helps the psychiatrist make that decision. Program fit, and I've already alluded to this, the safety of the people that we're working with. Obviously, if we have someone who's acutely suicidal, we have to help keep them safe. And so will determine a particular fit. That's not the type of person that would go into a partial or an IOP here where they're going home at nights. That's a person who would come into an inpatient unit or a residential setting. On the other hand, there could be dangerousness to other people. Sometimes this is triggered by psychotic process. Sometimes this is very commonly triggered if people have substance abuse problems by their alcohol or street drug abuse. Finally, we're going to make a program fit by the level of care that occurred in the past for this individual. That one's not quite as simple to see at first glance, but just give it a thought for a minute. If a person's been at another place, perhaps they've even moved from a different state or they're getting care in a different state, and they are in a partial hospitalization, so they're not on an inpatient unit, but that failed very badly for this particular person. Well, when we're trying to bring them here to get help, probably doesn't make sense to put them into our partial program. We already have evidence that the partial program did not benefit this person. So depending upon how their previous care went, it gives us an idea of what we're going to do here at Rogers. That person might benefit more from a residential setting. What you can see about all of this is that throughout the interview, what you are doing is gathering information that's going to allow us to get a program fit. Information that allows the psychiatrist to determine the diagnostic fit. It allows the psychiatrist to determine the severity of the dysfunction. It allows the psychiatrist to determine the safety fit. And it allows the psychiatrist to determine which type of program. Something from an IOP, where the person might be here 3 or 4 days, maybe for 3 or 4 hours a day, to a partial hospital, where they're here probably every day of the week except the weekends, for a full day, to an inpatient unit, to a residential setting, where actually people live here for a while. So this is what we're doing, and this is what you're doing every time you answer one of these lines. Now, the goal of the training, and what we're going to have here, is roughly about 9 modules. They tend to vary between about 10 minutes to maybe 20 minutes in length. And the goal is a pretty simple one. We want to create a set of interviewers on these phones that are sophisticated and very informed interviewers. And what we want that, and why we want that, is the more sophisticated and informed you are, the better you do these interviews. The better you do these interviews, the more likely we can help and heal these people. Now, how do we go about trying to train people to a level of sophistication and informed interviewing process? Well, I want to introduce you right off the bat a fairly sophisticated idea. In fact, I will tell you that many mental health professionals who are doing interviews every day, if you ask them what a standardization or scheduling is, they might not know exactly what these terms even mean. So let's take a look at these terms because they're actually of value to us. The standardization of an interview. In any interview, I can tell you how standardized it is. It's a fancy word that just means one thing. How much data do I have to gather in the time frame that I've been given? Now, interestingly, of course, one of the most difficult or highly standardized interviews is something that your master level clinicians and psychologists and psychiatrists are doing, which is a 50-minute full intake with a differential diagnosis and a biopsychosocial spiritual assessment. Trust me, these are really tough interviews to do. Huge amount of data to be gathered in 50 minutes. But truth be told, the interview you're doing is a pretty highly standardized interview. You have a relatively short period of time, and because Rogers has so many different types of programs, we have to gather so many different bits of information to make sure we get our program fit. So actually, it's a pretty highly standardized interview. Now, the next term to help you to understand what the interview is that you're doing is called scheduling. What we mean by scheduling is quite simply, how are the questions themselves phrased? What are the actual words used? And then the second thing is, how are they sequenced in the interview? Well, the interview you're going to do is a pretty highly scheduled interview. On the good side, one of the things is, at some level, it makes it a particularly easy interview to do because basically you're going to have an idea of what questions to ask when, and actually this is a pretty scheduled interview. There are specific phrasings. In fact, you will be reading many of these questions. In fact, I would argue that probably almost 90% of the questions you're doing are actually read. Now, that raises another interesting issue, though. When you read a question, it has to sound like you're just saying it to the person. And there's a little bit of a skill to that, which we'll be helping with our training for you to get. The trick is, though, these questions are written or designed, and I spent a lot of time doing it, that actually they sound very, very conversational to people on the other end of the line. What you're going to bring to the picture, sort of more spontaneous, is your personality, your engagement, and your empathy. And that's the stuff that's going to be sprinkled through the interview, and I'm sure you're going to do that very, very well. Now, let's look at something else here. How do we become an informed interviewer? Here's the bottom line. I am convinced that even though these are highly scheduled interviews, you're being told when to ask the question, you're even reading the vast majority of the questions. I still think it's important for the interviewer to understand two things. One of the things they want to understand is the phenomenology of what these mental illnesses look like and what it's like for people to experience them. The second thing is we want you to understand interviewing technique. Now, why are these two things important? The more you understand these things, as you're asking these questions, even though you might be reading them, the bottom line is you got an idea of why you're doing what you're doing and when, so that if things don't get the information that you need, you recognize it and you have some ideas and tools that we're going to give you to sculpt the information a little bit better so that you make sure that you're giving this patient the best chance to get the best triage from that psychiatrist. One of the things, the phenomenology, a fancy word out of Europe actually, the phenomenologists were actually philosophers and psychiatrists and psychologists on the European continent, first born probably in the 1800s, who liked to focus on the phenomena, ergo what is it like to experience life as a human being. So they're very interested on what makes people unique and how people actually experience the world around them. What we want you to really understand, and most of our modules are about understanding what are the symptoms of these mental illnesses like, but not only what are the symptoms, what does it do to a human being to be hearing voices? What does it do to a human being who feels forced that they have to wash their hands, hours and hours? And if you can think about it, it does a lot of bad stuff. It's not just the problem is the washing of the hands, it's that the patient and the person now feels that they are inept, that they are letting people down, they've become guilt-ridden, they have to leave their jobs. And that ineptness and that feeling of guilt and shame, you know what? That's the thing that ultimately leads a person to pick up a gun. So what we want you to understand is, what is this pain like? Now, why is that important? I'm convinced that when you ask these questions, whether we wanted to or not, our understanding comes through to these patients. And if you really do understand the pain, if you get it, if you understand it, you are going to be more empathic. The patients will hear that in your tone of voice. You will know when to back off a little bit or when to add a little bit more of the engagement process to them. It'll make a huge difference to them. They really understand they're being listened to. By the way, one other thing that we do here that's quite, I think, important in the design of this. We type stuff in sometimes when the patient is actually answering a question. We only do that with things that are demographics or background information. One thing you'll notice in this interview, and boy, I'm a huge believer in this, when this patient is describing their symptoms, when this patient is describing their pain, when this patient is describing their stresses, when this patient is describing their spiritual beliefs, or this patient is describing what is to be to them, we don't type at all here. We just listen. And what you do is, I think, a nice way to think about it. When you're on the line with these patients, pretend that one of your best friends just walked into your room and they clearly looked troubled and they said, "I need to talk to you." Listen to these people the way you would listen to that friend. Do that and you'll do a lot of good in this place. The technique, well, once again, these are pretty spelled out questions, but for instance, you're going to learn about a thing called normalization. You're going to learn about a thing called a gentle assumption. You don't actually have to phrase the questions that way. You're reading them. They're already phrased that way. But what we do want you to know is to say to yourself, uh-oh, I know what I'm doing. I'm using a normalization, and here is why this is designed this way, and here is what I'm looking for as far as the impact of the question on the person. This makes for a very savvy interviewer. So even though it's a pretty scheduled interview, the more you understand the pain of your patients and who they are as human beings, and the more you understand about interviewing itself, you're going to be that much better. The goal here is we make you better, you heal people faster, and that's what we're all about. Now, at this point in time, we're done with our first module. As you can see, though, our second module, we're going to look at the interviewing process itself. We'll look at particular interviewing principles and particular interviewing techniques that will be of value to you. And until next time, I hope things go pretty well for you and you get excited about what you're doing. Thanks.